further ado, ladies and gentlemen, you all came to see Dr. Peter Betz, and I'd like to introduce him to you right now.
How is everybody this evening? Good. I like that. So I'm here today to really facilitate a discussion about a whole bunch of different things that may come up about taking care of folks with dementing illness. So what I'm going to do is really start by talking a little bit about what we can do for folks that have dementing illness, what are some of the interventions that we can have, maybe a little bit about what dementia is, and arguably my role, since we've been talking about that here at Runk Pratt, in the role that Runk Pratt may very well participate in and be in an instrumental role in providing that care and support over the course of time. So my real hope is that through the few words that I have that I'm going to spew out to you, I will sort of provoke some questions, and I'm very happy to answer any questions that you have and tell you what I know, I tell you what I don't know, tell you why I say what I say, so that we can hopefully help alleviate a lot of misunderstanding, a lot of fear surrounding the illness. That's one of the greatest problems that we have with this disease process, is that just like many unknowns in medicine, we oftentimes are more scared of the label than actually we end up being presented with if we really just sort of were to take it one step at a time. Dementing illness is something that we often get very scared about. When I was a little kid, not knowing any better, we would sort of joke with our friends, and if they did something silly, I would say, "Oh, you're just being demented," right? I had no idea what that really meant, right? Now, being a geriatric psychiatrist, I know a lot about the idea of what dementia is. Dementia is not a pejorative term. It's not intended to bring somebody down. Somebody with dementia is not less than I am. They're not less intelligent. They're not less capable. They're not less important. They're not lesser in any way. They're different, right? They've had an illness that's been affected, that affects their lives, kind of like diabetes, right? It doesn't make any less of an individual. It just means that we got to adjust a couple of things. Dementia is really the word we use in medicine to describe anything at all that affects the brain and causes us to have some brain difficulties, whether that is memory troubles or whether it's executive function like planning and organizing and sequencing. Maybe it's some language difficulties. Maybe we have trouble moving our bodies, and it puts us in a position we're more likely to have falls, right? And so in that way, everything that leads to that kind of syndrome is called dementia. There are many different kinds of dementing illness. So Alzheimer's disease, which is what you guys often hear most of, is one kind of dementia. There are actually many different kinds. So for example, you can have dementia of Alzheimer's disease. You can have vascular dementias. That means dementias related to blood flow of the brain, whether it's one big stroke, lots of little strokes, or actually something called hardening of the artery, something called Binswanger disease, which is an old term that I think is coming back into at least some of the medical literature again. There's other types of dementing illness like Pick's disease, frontotemporal dementias. We have Lewy body dementia. We have dementia of Parkinson's disease. We've got dementias related to normal pressure hydrocephalus. We have all sorts of infections and things that can go on in the brain. So when somebody uses the word dementia, it's kind of like saying the word infection. Well, we kind of know what it means if I said you had an infection, right? Well, you want to know where is it, right? Is it my toe or my ear? And then you want to know, is it bacterial or fungal? You want to know more information. So the word dementia by itself only tells us a little bit about what's going on. You might want to know more information, like, is it from Alzheimer's disease? Is it from vascular disease? Now, what's interesting is that the most common cause of Alzheimer's, or common single cause of dementing illness, is Alzheimer's disease. But if you were to take a look at everybody that had dementia, the most common cause is actually a combination of Alzheimer's disease and some hardening of the arteries. And there may be a combination of those two things that play a role. So unfortunately, it's not always so cut and dry. It turns out that many of the very same risk factors that cause heart attacks and strokes and hardening of the arteries are some of the very same risk factors that lead to brain difficulties and brain dysfunction, right? Like Alzheimer's disease. And so most of the time in medicine, there's an evolution that occurs over time, right? So way back when, if you think back 20 years, 30 years, 50 years, we used to say everybody that had some difficulty thinking as they got older had simply senescence or senility, right? And then what did we say? We said everyone had hardening of the arteries, right? And then, right, talking about the 80s or so, late 80s, early 90s, we knew better than ever. We all had Alzheimer's disease, right? Because we knew how to diagnose it, we knew what it looked like under the microscope, we had all sorts of different tests to test for it, and so as doctors we thought we knew everything, right? And then it turns out that we didn't know everything, that we ended up having a lot of hardening of the arteries. So maybe we were right way back when we used hardening of the arteries and not Alzheimer's disease as a definition and a description for some of the things that are going on. And now we're learning more and more that, in fact, there are maybe Alzheimer's diseases, just like there are many pneumonias, right? And that there may not be a clear line always between Alzheimer's disease and Lewy body disease, because you have Alzheimer's disease with Lewy bodies, which is different than Lewy body disease, which often can overlap with Alzheimer's disease.
I can't get that word you're saying, Louis something.
Lewy body disease. That is arguably the second most common single cause of dementing illness. But you're exactly right. Many people haven't even heard of it. They say, gosh, what's up with this? And most of the time it's because Alzheimer's disease gets a tremendous amount of press, and we don't often get to talk about other kinds of dementing illness. And many times it's because we just don't, when it's already a difficult thing to understand, we oftentimes don't go into all of the details of the many sort of subtypes of dementing illness. And so it's common that folks don't always know the difference between those kinds of processes. So in the brain, we know that when somebody has dementia, there's a disease that's going on. It is not normal aging. And I think that's a very important thing to identify. Because I've got a lot of folks that come to see me and sort of say, gosh, is this normal aging or is this something more? Or they come to see me in dementing illness and the family says, gosh, we thought that this was just normal aging for the longest time. How do you tell the difference? Well, it actually is pretty straightforward, as much as you can say that mud is pretty straightforward, right? As we get older, our bones and our muscles, they change, right? We walk slower, we don't jump as high. It's just a matter of life, right? Well, our brains, just like our bones and our muscles, they age. They get older. And so as we get older, we slow down. So it's normal to take a little bit more time and effort to learn something new. It's one of the reasons that we're so proud of our friends and family that go get a new degree from college at the age of 45 or 50. Not because they're not as smart as the younger kids. Not because they were smarter when they were younger, but it takes so much more effort to master that new material as we get older that it really is a tremendous accomplishment. The speed of our processing is different. But we should always be able to do what we used to do when we were younger. So if we start not being able to do the things that we were when we were younger, right? That means that there is some kind of hiccup in our brain function. And that suggests, that's a red flag. It suggests that there may be something more going on. There may not be. There actually is, believe it or not, a little bit of evidence that suggests that even those moments where you can't remember somebody's name, and it just happens once in a blue moon, or you misplace your car keys and you don't know where they are, right? Those things, not too long ago, 2 or 3 years ago, I used to say, don't worry about it, it happens to everybody, including myself, right? Which is why I like to say that. But it turns out that those little slips of memory, even in otherwise folks that have no evidence of dementia, may be in part related to the same process in the brain as the other more consistent memory loss that we find in dementing illness. So there may be more overlap than we thought. That's not to be catastrophic. That's not to say, oh, you forgot some small detail like the milk when you went to the grocery store. You're doomed, right? I'm not suggesting that. But my point is we're learning a lot more about the body, and that it may not be either all on or all off. We've known now for a long time that the process of Alzheimer's disease may start when you're very young, maybe even as young as in your 30s, right? Just like the heart attack you have when you're 62 began with the Big Macs you ate when you were 18, right? And so it may be a whole lifelong process rather than a singular sort of event or crisis. The treatments that we can use to manage dementia illness are unfortunately a little bit limited. So what we can do is identify the cause as best as we can. Now, unfortunately, in medicine, like in life, things are not always black and white. But if there's a treatable cause, and we can reverse that cause, we can have a substantial improvement in somebody's ability to function. So for example, I'm in my clinic, and I see somebody comes in, and they're stumbling a little bit, their thinking is not very good, they're slurring their speech. I talk to the family, they've had a decline in their ability to clean themselves, they're getting a little bit of urinary incontinence, and it's starting to be a problem, and everybody's worried about their confusion. Well, if you didn't know any better, right, you wouldn't know that that's the classic triad of normal pressure hydrocephalus. A brain scan and actually some direct intervention, putting a tube from the pools of CSF in the brain to the belly, sometimes can cure memory troubles. Isn't that great, right? I see folks that have come into the clinic that have progressive memory troubles, and they have an overgrowth of the meninges, or the covering of the brain, called meningioma. It's a benign growth, right? Kind of like a skin tag, right? It kind of is just taking up space, but it's not really that bad. Well, it turns out that if it's impinging on the brain, it can sometimes be. You go in and you lop it off, and guess what? They get better. Sometimes people can have a fall and bump their head and have a very slow bleed on the brain. I've had a gentleman that I take care of now who's had that twice. And in fact, they go in, they take out the blood, and guess what? He does well and has no dementia. I love those kinds of stories. And those are the stories we always hang our hat on, right? Because I feel really smart when I get those, right? I can get them fixed up, right? But unfortunately, like many chronic illnesses, we don't always have the fix. Like diabetes and high blood pressure, many forms of dementing illness are persistent, they're pervasive, and they're progressive. And that's a really hard thing to manage and to cope with. So I'd like to talk a little bit about two different kinds of things. One is what we can do to try and prevent or eliminate the risk of getting Alzheimer's disease or other types of dementing illnesses, right? And then really, what do we do after we know that we have this illness? What kind of interventions can we think about sort of intervening with? So if I was to be, let's say, me, right? And I know that in my family, I have a family history of Alzheimer's disease. So I already know that I have a genetic loading for that I have a higher risk of getting Alzheimer's disease than somebody who doesn't have any family members with Alzheimer's disease. So what does that mean that I need to do? Right? Well, it turns out that what doctors have been saying since the Middle Ages, right, actually are continuing to be the most important preventative measures that we can have today. So it turns out that even to prevent Alzheimer's disease, keep your weight under control, right? The extra 20 pounds that I'm sitting with up here, right now, way too much. I need to work on that. And I'm not even morbidly obese. If you're carrying just this amount of extra weight, you have an increased risk of developing dementing illness. If you don't manage your high blood pressure, if you don't take really good care about the kinds of sugars and diet you have and manage your cholesterol, manage your sugar, you have a higher risk of developing Alzheimer's disease. So those are all important things, and we've known about them for a long time, right? Even the government, which is one of the slowest moving organizations that I could possibly think of, has even finally come out and said, listen, we're tired of suggesting America kills itself with its diet. We're going to revise our diet recommendations, right? And you know what their revised diet recommendations are?
Less sugar.
Less sugar, right. It essentially says a diabetic diet is the healthiest diet that you can eat. And for the most part, that's true. There are some variants on that we can talk about. There's special diets like a Mediterranean diet, and there are other kinds of unique specialized diets that may have some benefit that's greater than that for dementing illness. But I tell you, if you eat a diabetic diet, that doesn't mean going no carb and doing some Atkins version of extreme living, right? But if you eat a diabetic diet, you probably are having a substantial better or an improved risk for developing dementing illness, even if you don't have diabetes. That's pretty powerful, right? Now there's been also a lot of press over time, and there's a lot of data that shows remaining cognitively active is a good thing, right? Exercising the brain is a muscle doing stuff, right? Remaining stimulated. Well, that's actually very important. There's data to clearly show brain activity is essential to maintaining our cognitive health and well-being. Now, most of the studies have been done on specific kinds of interventions, like doing crossword puzzles or not doing crossword puzzles. Well, I gotta tell you, I hate crossword puzzles. Right? So, guess what I'm not gonna be spending my life doing? Something I don't like doing, right? But the concept is real. And so I'm going to do something I do enjoy doing. Like I like playing chess. So I'm going to play chess, right? I'm also going to tell you that many of those activities that we used to think are good may not always be so good. Like solitaire, fun, not so helpful. The work of something on the brain to have a benefit, right, needs to be hard work. If it's easy, that doesn't mean it can't be fun, but if it's easy, it ain't what you think it might be, right? So for example, let's say I was standing here and there's a fantastic buffet out there, right? I mean, I tell you, the food out there is fantastic. Let's say I walk out there and I grab myself a sandwich and I come in here and eat it. How much exercise do you think that is?
Very little.
No, it's no good exercise, right? But let's say I go sweat for 20 minutes, right? By running around the parking lot, right? That's exercise. It was hard work. That doesn't mean I don't enjoy running around the parking lot, right? It just means that it's got to be hard work for it to be exercise. Same thing with the brain, right? So that's one of the reasons and one of the fallacies. You've heard about the Lumosity, right? And the fact that they've gotten, in trouble recently because they advertised more than they suggested. That doesn't mean luminosity is bad, right? But just make sure that Luminosity is a website where you can play brain games, right? But if you play the brain games, right, they're based on good data, interestingly enough. They're based on the very tests that you use to evaluate the cognitive capacity in people. So if you practice and play the tests that we use to evaluate cognitive abilities, theoretically, the idea is that you would get better at those cognitive abilities. I know it's kind of complicated, but that's the theory. The problem is that there's not been a study to demonstrate that, right? So they made some claims that weren't quite accurate, but that doesn't mean it's all bad. The difficulty with this is, and I've played some of the Lumosity games, right? Is that when you're done playing the game, does it feel like it was hard work? Anybody here who's played that website? No! It's not hard work. You've got to work hard. It's kind of like reading. Reading is good, right? Reading a romance novel, right? A mystery, it's good. Don't get me wrong, but it's not going to work the brain, right? Reading something about philosophy, reading something about an idea or a concept that you have to really ponder and think about, right? Reading about something about history, not just in a narrative or a story, but really understanding the complex interventions and things that have happened politically and sociologically and sort of chronologically. That's hard work, right? That's something that might benefit you, right? So that's what I'm suggesting, is that using the brain is key. But the most important thing of all of that, the most important thing is to play tennis. There you go. Right. No, I'm just being, right, playing tennis. Well, it's not necessarily just tennis. I happen to play tennis, and so I think it's the best thing. But it turns out physical activity, right? The more physically active you are, the better. And I'm talking about hard work. Now, I love to play tennis. Matter of fact, when I'm done here, I and 3 other guys have a date to go play tennis. Late at night, because we love playing tennis, right? There's nothing wrong with that. If you love doing something, it's great. Think about tennis, though. It's a silly game, right? I get to stand out there with 3 other adults and these little rackets, and I bat a fuzzy yellow ball back and forth, right? I mean, it's a really silly game.
You're competing.
But I have a love of that game, and I don't know what it is. There's got to be something addictive in the ball fuzz or something. I don't know what it is, but I love that. I've got some friends that don't really enjoy playing tennis. That's all right. They might play basketball, right? They might really enjoy playing golf, but without a golf cart, right? They might enjoy running, right? I enjoy running. Some of my friends would say, God bless those who like running, right? Because it's not such a big enjoyment to them, but some people really do enjoy it. The point is, have fun with whatever you're doing, but it's got to be hard work. When you're done, you have got to be absolutely beat. If you're not tired and worn out, it ain't good work. And so I know I'm throwing the bar pretty high, right? So I've got a lot of folks that say, oh yeah, I like to walk around the block. Well, that ain't going to cut it. Now you got to start somewhere, right? If you've been very sedentary and you're not doing very much, that might be all the work it takes to really get your your heart pumping and you get sweat flowing and all sorts of stuff. But you got to do hard work. Nothing in this world is easy, right? And we all know that. So I'm telling you all the stuff you didn't want to hear, right? But so those are the things to think about to prevent this illness, right? Remain active. Play chess or your version of something that requires a lot of focus and concentration. Play tennis or something that is fun and enjoyable and hard to do, right? Eat right, which is a diabetic diet. Hard to do that, right? Lose weight. I tell you, I know that's hard to do, despite playing a lot of tennis, right? Because I like to eat. Not always a good diabetic diet. That's a problem, right? I mean, I get it. I know it's not easy when I say these things, right? That's what we need to do. Cholesterol under control, high blood pressure under control. But it's amazing if you think about it. If you just exercise a ton, how much easier and better all of those other things will be. Because what does the doctor say when you have high cholesterol? Exercise. If your sugar's not good, exercise, right? If you're overweight, exercise, right? Is there a theme, right? Do more of that. That's key. So let's say those are the things that you do to try and prevent the onset of illness, right? And matter of fact, it's exactly the kind of talk that a cardiologist would give you if he said, well, how do I stop you from having a heart attack or a stroke, right? You'd be saying the same things, right? Fewer Big Macs, more jogging around the block, right? So let's say we're in the unfortunate position where we have the illness. Now, doing all the right things does not prevent you from getting ill. It simply reduces the risk, right? So if you do all the right things, it may be as simple as taking the onset of dementing illness to where it causes a dysfunction in life, right? And moving it from 65 to 72. That's 7 years of life, right? Yeah. So it's not that at 72 you get upset because you have the illness and you've done all those good things in life. It may be that it really is 72, and that by itself is a gift, right? It's important to keep those things in perspective. So let's say you have the illness, and we need to intervene because we want to take care of you, right? What kinds of things do you do? Well, there's a couple of things. One is that you do all of what I just talked about, right? Start now. It's not as good as starting yesterday, but it's better than starting tomorrow, right? And that's some of the things that we just heard about. There's a lot of activities, even if we're limited, to try and help perpetuate activity and movement, right? If you can't run a 10-miler because you're on a walker, right? That doesn't mean that you don't enjoy and be as active as you can doing what you can, right? That's key. There's always things and ways that we can modify, and there's a whole practice within medicine called physical therapy that's married to another whole practice called occupational therapy that have tremendous inroads and knowledge about how you can achieve these very lofty goals, even if we have tremendous limitations physically or otherwise. So I really would encourage you guys to use that to the greatest that you can, greatest ability that you can. So let's say we have dementing illness. You've come to the unfortunate Dr. Betz, and he has said, you've got Alzheimer's disease. What do we do? Well, there's a couple of different interventions that we have with medicines and the like. You will read and continue to read about all sorts of different things in the media, much of which are based on at least some evidence of there being a truth behind it, most of which don't really have great data. It's kind of weak. So for example, I had one gentleman, I like this story. I had one gentleman a couple of years back, he was reading on the internet, and I don't know where he found it because I haven't been able to find it, but he was convinced that dill tea was going to cure his Alzheimer's disease. And I told him I wasn't sure that dill tea would cure his Alzheimer's disease. I said, well, I can't promise you it won't, because I don't know that either, but I just don't know. Anyway, he got very upset with me, fired me, and walked out. And so, it's okay. But you have to be careful about what you read and what you learn about. My recommendation, if you're going to learn about what to do with Alzheimer's disease or any form of dementing illness, is go, and you're on the internet, right? The internet is almost ubiquitous these days. Go to sites that you know are well vetted. That means that they're well thought through and they're based on what we know is fact. So for example, the Mayo Clinic, Johns Hopkins, Harvard, UVA, you know those websites that if they're going to post something, there's probably a very responsible cadre of individuals doing research and they know what's there is accurate, right? The sites they refer you to, so for example, you go to the Mayo Clinic website and they said, oh, go to peterbetz.com, right? There is no peterbetz.com, at least not that, right? Then you probably know that that's a pretty good jump, right? Because they're vetted and they said this website is good, right? But the moment you start going one more step away makes it more likely that you will end up being confronted with something that may or may not be accurate. It may be good, but it may not be. But it's harder to know. And I've got to tell you, sites that have pretty kooky information sometimes are the most professionally looking sites. So just sort of be aware of that. So I would stick with sites that you know. And then, if, for example, if you were to see me or somebody else who's an expert in the field who understands the nature of dementing illness, if you find something or read something that you think is interesting, write it down and bring it to whoever you're going to talk to about it. And this is what I tell you. It's kind of like what I said before, right, with questions. I'll tell you anytime what I know. I'll tell you what I don't know. I tell you why I say what I say. My goal is always to partner with, not to declare orders or be draconian in the way that I present rules or knowledge or things like that. And that's very important, right? Mostly because we don't have all the answers. So the idea is really to get the best information we can. One of the things that I think is very important to point out is that there is not one right answer, right? A lot of folks come to the office and they want to know the solution for whatever problem they bring in, right? There many times is not a solution. It's what's best for you and your family. And that's where a lot of expertise can come and play a role in putting that information together, right? So we work together as a team for that, and that's, I think, very, very important. Yeah.
He's my doctor. And I came with him, asking him about this medicine. He said, I don't think it's going to help you, but the shareholders will love you.
I say that from some time to time, right? Yes. Fair enough. So let's say we've got some information about what to do. So you've got Alzheimer's disease or one of the forms of Alzheimer's disease, right? There's really two medicines that we know can slow the rate of cognitive decline. They are modest. They're not the answers. The problem is that my Alzheimer's disease is going to be different than your Alzheimer's disease, right? It's going to be a little bit different than yours. And it turns out that I would argue that by the time I get Alzheimer's disease, we're going to learn that I have Alzheimer's disease type 2B. And then you might have Alzheimer's disease type 3F. And there's going to be different variants, just like we have different kinds or sources for pneumonia. And what we're going to discover is that certain interventions are going to be better based on the kind of illness you have. Just like all skin cancers are not equal, right? All Alzheimer's diseases may not be equal. And one of the problems that we have in medicine is that we take a medicine that we have. In this particular case, we'll talk about cholinesterase inhibitors, which is one of the two kinds of medicines that I would talk about. I'm not going to bore you. You don't have to worry about all the details. But what we do is we take everybody that has Alzheimer's disease and we give them this medicine. The problem is that for a subset of those individuals, they will respond exceptionally well. For a small subset of folks, they'll have a moderate response. Some folks won't get any response. Some folks won't tolerate it and will be very unhappy with me that I gave them a medicine that caused them side effects. And so not everybody is going to be equal in that way. So we can't always expect that every medicine is going to have a tremendous result. I've had a couple of folks that I've treated with these medicines, like Aricept and Exelon and the like, or Namenda, which is another class of the medicine that oftentimes works together with them. And I've had folks have such a robust response that 10 years later, I have seen very little decline cognitively. And I have a conversation, and I say, I'm not sure I got it right. I mean, I thought it was right based on everything that we had talked about way back when, but it's not getting worse. And we go back and we revisit things, and we still come up with the idea that, gosh, I don't have a better explanation for what's going on. And we have to work with that. I've had some folks where I give them medicine, and they have a very rapid decline. Not necessarily because of the medicine, but I can't say the medicine is innocent either. So we have to talk about that, because it's not one size fits all, right? Medicine is not always very black and white and clear. Making the diagnosis of Alzheimer's disease is not very black and white and clear. Do you know that making the diagnosis of Alzheimer's disease, they did an interesting study. Making the diagnosis of Alzheimer's disease based on, if you look at somebody, let's say do an autopsy, and you look at somebody's brain and you're able to look for plaques and tangles and signs of Alzheimer's disease in the brain, and you take a look at the diagnosis of an expert who diagnoses Alzheimer's disease, and you look at the correlation, there's a 95% correlation. That means if you walk out of my office and I say, you have Alzheimer's disease, there is 95% of the time it exactly matches what happens at autopsy. It is an old tale that you can only diagnose Alzheimer's disease by autopsy. That's not accurate, right? However, it might be that you leave my office and I say, I think you have Alzheimer's disease, but it's not very or absolutely clear. Then it may not have such a high correlation. If you look at the correlation between being able to diagnose stroke-related dementing illness, it actually is lower than diagnosing Alzheimer's disease. You'd figure that was straightforward, right? You got a stroke, you can't think so well now. Stroke caused not thinking so well now, right? Pretty straightforward. But we're actually less good. That's not proper, right? It's because I should do more crossword puzzles. Than diagnosing Alzheimer's disease. So we're pretty good with that, but not perfect.
So Alzheimer's, can you pass away from just Alzheimer's and nothing else? I mean, is that?
That's a very good question. The answer is no. The question is, do you die because of Alzheimer's disease? And unequivocally, the answer is no. The Alzheimer's Association will absolutely tell you it's the 6th leading cause of death. They're lying. They're doing that because it allows them to get the very necessary attention of how important it is to treat Alzheimer's disease. What they really should be saying is that Alzheimer's disease is a prominent illness that is a part of the death of the 6th most common cause of death. But Alzheimer's disease actually doesn't kill you. It causes you not to be able to swallow well. It causes you not to be able to fight infections well. It causes you not to be able to heal wounds well. It causes you to have more difficulty with eating the kinds of things that prevent you from having a stroke. It causes a whole number of things that increases your risk of death. And so indirectly, it is very much a part of that. But of itself, no. And it's interesting, I'm a part of the medical and scientific committee of the region, our region of Alzheimer's disease, and everyone on that committee says exactly the same thing. It's Alzheimer's Association is a fantastic organization. This is not anti-Alzheimer's Association, right? But that bit of data is, I think, a little bit misleading. So just sort of, just sort of know that. Yes, ma'am?
Question. If you had Alzheimer's in both sides of your family, mother and father, what are your chances of inheriting it?
Well, that's a good question. So, where I talked about, I have a family history of Alzheimer's disease. If you've got somebody in your family that's a first-degree relative with Alzheimer's disease, first degree means mother, father, sibling, child, right? Well, not too many of us have kids that have Alzheimer's disease. Although I've diagnosed Alzheimer's disease as early as in the 30s. But that's in a special population of Down syndrome kids. Turns out that you probably have double the risk of developing Alzheimer's disease. But it doesn't mean you're going to get it. It just means you have an increased risk. The caveat to that is that if your family member had early onset Alzheimer's disease, that means the onset of dementing illness before about the age of 55 or 60. Early onset Alzheimer's disease may very well be related to a singular knockout of any one of a number of at least 4 different genes, more than you want to know, but that risk is 50%, right? Mom got it when she was 50, you've got a 50% risk of getting it when you're 50 or earlier.
Is there a test to determine if you carry the gene, if you are a first person?
If somebody in your family is young and they develop Alzheimer's disease, there is genetic testing for those specific chromosomal abnormalities that make you an increased risk of developing Alzheimer's disease. So you can get that done. There is no good testing for if somebody has a late onset Alzheimer's disease if they have, you impart an increased risk for that disease. So if somebody had it when they were young, there may be a familiar component. The majority of them are not related to that one of those 4 gene knockouts. But if you have a family history and it's gone from generation to generation and it's been a persistent problem, then in fact that there are. The majority of those are actually in German families, interestingly enough, for whatever reason.
And what?
In German families. So,
Are the risks exponentially higher when you have like a sibling with early onset and your mother had later onset and a grandmother that had it?
Not necessarily, for the early onset dementing illness, right? If you have the same biological parents, arguably you have, if it was related to the single genomic knockout, you have a 50% chance. If just family members have had it, then you have just an increased risk, but it doesn't mean that you're necessarily going to get it.
Okay, but the combination doesn't increase the risk
Right.
further.
It doesn't further increase the risk. And even those family members that have it at an early age may very well had a compilation of a whole number of what are called multifactorial interventions that made them at increased risk rather than that single gene knockout. And that's a complex, so that way you've opened up the door to a very complex discussion about genes and the like, because you'll hear a lot about ApoE4 and ApoE2 and ApoE3, which are risk inheriting genes, but not whether you're going to get the disease determining genes. And it's been clearly written and discussed in literature that we do not test for them and should not test for them in the general population. I've had a couple of families say, I want to be tested, and I say no, and they sometimes don't like that. But it's not really appropriate to test in those kinds of circumstances because you're not gaining anything for the cost of the test.
Can I ask, the subsets that you referred to earlier, are they, when you inherit, this family risk factor, do those subsets, are they kind of inherited too, or not so much?
The subsets in what way?
Like, you said F5 or B2.
Well, that's a good question. We don't have all the information yet.
Okay.
But I can tell you that one of the most substantial reasons for thinking that there are maybe different Alzheimer's disease is that if you have 4 different chromosomes, all of which have different proteins on them, each individually give Alzheimer's disease, we know we at least have 4 different types of Alzheimer's disease, right? And then we've got the kind of Alzheimer's disease that doesn't have a single gene sort of knockout, but we have other genetic vulnerabilities that are sort of playing a role in that. So there's a whole spectrum and a whole gray area that goes along with that. So unfortunately, it's not black and white, and that's where we are in medicine. We just don't have the answer for that. We don't always know.
Going the other direction on it, what about, like, none of my great-grandparents had any dementia at all? None of my grandparents, and then my father gets it. I'm just kind of baffled in the it's just the change in times that we're all, I feel like everybody's gonna have cancer and Alzheimer's. It's just.
Well, what I can tell you is that's a really good question. So there's two things that may very well play a role in that. One is that 2 generations back, they may not have lived long enough, or they may not have been properly recognized or diagnosed because we didn't do that at that time for a variety of reasons, and there's a whole sociologic issue that goes along with that. The other is, so we talked about earlier about the risk factors and how to prevent Alzheimer's disease from occurring, right? If you were to think about the one thing that is common across all of those is what? Gluttony, right? That's what we do. We eat too much. We don't move around enough, right? We like all of the bad things or all the treats in life way too much, right? Guess what that leads to? An increased risk of Alzheimer's disease, right? So what's different in your dad's generation than the previous generation? They had much more access to all of those things. So they didn't work as hard. We didn't have to, we had different diets that were certainly more processed, right? More processed foods are not good, right? The diabetic diet, people have talked about it being the anti-white diet, right? So you avoid things that are too white, right? White bread, That means not only white bread, but processed flours, right? So sugars, like white sugars, right? Everything that has sugar added, right? And so it's an interesting
dinners.
phenomenon. TV dinner, right? Absolutely, and those kinds of things. And so that may very well play a role as to why there's an increased risk generationally. And matter of fact, that's been borne out. If you look at epidemiologic data, that means population-based data, what we see is that there is a progression and an increased rate of Alzheimer's disease beyond simply the population getting older and factoring in that we're better at making the diagnosis now than we were previously. And undoubtedly it has to do with this massive problem of healthcare that we have in the United States, which is addressing a population that's getting bigger, right? I mean, we're all becoming fatter, and it just is what it is. I mean, I know I got this problem, right? But I got to tell you, we all have this problem. And, you know, Lynchburg is one of the fattest cities in the country, right? We learned that a couple of years ago, right? I mean, it's amazing, right? I didn't think that's where I was going to live, but we live right there, right? So guess what? Play more tennis, right? I'm just saying, you got to do some of that. So, so that may very well play a role as well in all of those things. Yes?
So you mentioned collapse and tangle. I've read something that is some of the early signs that can be actually seen in a CAT scan or whatever it may be. Is kind of research is going on in that, and what causes it? Is there much understanding of that process?
Actually, there's a huge amount of understanding of that process. What we don't know is why that process begins, which is a little bit troublesome. It's kind of like sleep, right? We all know we need it, and we all know it's either good or bad for us, right? But to this day, we have no idea why we sleep, right? We're actually starting to break that. That's a whole other interesting. We're starting to understand why we might need sleep. But to answer your question, we know what happens in Alzheimer's disease, but we don't always understand the why or the how. What I can tell you is that the structure of the brain with Alzheimer's disease looks, guess what? Yes. Normal. Right? So if you look at a CAT scan or you look at an MRI, many times early stages of Alzheimer's disease are normal looking brains, despite clearly peoples that have abnormal brain function. That's very important, right? How many of you would be able to look around the room and pick out who has diabetes by how they look? Or who has high blood pressure by how they look? Not too good, because our function of the heart or the pancreas, right, may be different than how we look. Same thing even if you take a picture of the brain. The brain may not look like it's not working so well, but clearly has disease. Matter of fact, I have a lot of folks that have had massive strokes, massive meaning half their brain, but very large strokes, that after 10, 12 years, you take a picture of their brain and the radiologist will say, normal, even though they clearly have physical limitations and weakness because of the residual effects of that stroke. It's not because the radiologist is bad, and it's not because the testing equipment was suboptimal. It's because our brains and our bodies are incredibly well able to heal themselves structurally, even if they're not able to fully respond sort of functionally. So going back to what you can, so what you say is that a CT scan or an MRI is not going to be able to make the diagnosis. A very common finding that is associated with Alzheimer's disease is a generalized atrophy or shrinking of the brain. And so you often see that, and it makes sense. You have some brain tissue death, then the brain is going to shrink. There's a little bit of atrophy that occurs with normal aging, just like our skin becomes less full of water and we see more wrinkles. Our muscles are not as big as they were, right? And that's just part of normal aging, right? Our hair turns white. We lose some of it. And those are some normal changes with aging, and so sometimes early on, it's difficult to dissect. Is this a normal aging change, or is this something more? The plaques and tangles actually represent to findings that are only identifiable under a microscope. And in a microscope, if you look at the cells themselves, the neurons, which are the nerve cells in the brain, inside the nerve cells, there are a bunch of tangles. Literally, they look like tangles, right? We're not better at that in medicine to describe that. Oh, it looks like a knot, right? And it's probably related to tau abnormalities, which is a particular protein in the brain. Then there are outside the cells this collection of stuff called junk, we call plaque, right? Just because it looks really like a plaque, right? And that's because of beta amyloid collecting in the brain. And so under the microscope, we see plaques and tangles. The interesting thing about plaques and tangles are this. Even the pathologists will say the definition of Alzheimer's disease can be best made by autopsy. And so they say, if you look at the diagnosis, they'll say, it depends on the number of plaques and the distribution of plaques in the brain, which makes sense. But there's no correlation with tangles and the diagnosis of Alzheimer's disease. Huh. But if you look at the severity of Alzheimer's disease, you'll notice that that's not so much predicated by the number of plaques, but by the number of tangles. Well, this is getting confusing, right? So if it was all just plaques and tangles, we would have solved it years ago. Matter of fact, did you know Lois Alzheimer discovered the plaques and tangles way back when, in 1907? Over a century ago, right? If this was the easy answer, we would have figured it out because we're that smart. We're not very smart, but we're at least that smart, right? So in that setting, there's a ton that we don't know. Matter of fact, there is some increasing evidence. You've heard about diabetes and glucose discontrol. There's an interesting twist on that. There was apparently a speaker that came to Roanoke and said Alzheimer's disease is diabetes type 3. Well, he was just trying to make a name for himself. But we do know that sugar discontrol can lead to an increased risk of Alzheimer's disease. And there may be a kind of insulin resistance in the brain that increases the risk of developing Alzheimer's disease. So not diabetes as you and I know it, but that chemical may very well have more of an effect than we think of before, right? So that's kind of interesting as well. And that may be more related to more related to the beta amyloid collection than to the tau sort of tangles that are occurring inside the cells. And so we're learning a tremendous amount related to all of these different processes. So what we're doing right now is we're at the stage of medicine where we're learning and we're amassing tremendous amounts of information about what is occurring. We just don't yet have the intervention point in order to be able to stop it from happening or to stop it from continuing to happen. So we talk about medicines, and I prescribe these medicines all the time, Aricept and Namenda, Exelon, you'll hear about those kinds of medicines. They have been shown empirically to slow the rate of decline once somebody has Alzheimer's disease by being essentially symptomatic medicines. They don't treat the cause, they treat the symptom. And that's why they're good, but they're not the answer. But that's okay. How many people in here have had their diabetes cured? Or their high blood pressure cured? We're no better at treating those illnesses either. We treat the symptoms, right? So we give you some insulin and we say the glucometer or the sugar testing is better. We give you a medicine and we say the blood pressure cuff says that you're better. But did you know that if you have bad diabetes or even not so bad diabetes and we control your sugar perfectly, you still have an increased risk of glaucoma and stroke and kidney failure and all those things? So the sugar level that we measure, as much as we think it's sexy because it's something that is discrete and we can focus on it, we can measure it, right? The disease process is much more than just that sugar level. If we control your high blood pressure, you still have an increased risk of stroke. It's just that we will hopefully push off that stroke 5 years. That's where the benefit of our treatments come in. And so Alzheimer's disease is in that process where we know a lot about what's going on in Alzheimer's disease, just like we know a lot about what's going on in diabetes, and a tremendous amount of what we know about is going on in cardiac patients with high blood pressure. But we don't always know the underlying etiology. For example, the overwhelming majority of hypertension patients are called essential hypertension. Do you know what essential means? Us doctors don't know. Right? Just is. Right? So we should call it essential Alzheimer's disease. It makes me sound smarter, doesn't it? So, because I don't know. Now, we have a lot of information about that, but we just don't have all the answers. And that's the problem that we have in our society, is that we can't answer all those questions. We do the best that we can. That's why there's an art that goes along with providing care. Right? If it was all black and white, it was all algorithmic, then we wouldn't need what we have here. Right? And so that's one of the things we were talking about when we started, right? Runk Pratt and what they offer, right? There's a huge cacophony of opportunities here, right? So you get the care that you might need on a number of different levels. You have increased socialization. For example, being with people. And this is data that's been out for decades, and we just pretend to ignore it. What's the most important factor of your life that will predict reduced onset of dementing illness and best physical health throughout your lifespan? The one thing. Bingo. Exactly. Significant others. People that you have in your life that you know that you can rely on if you need them, even if you never need them. Now, I got to tell you, in my world, I have 1 billion contacts. I see people all throughout the day. I see people in the morning. I see people in the evening. I have a ton of people that I interact with. I only have, unfortunately, I have more than I deserve. But there's only a small subset of those that I would call close and intimate friends. But there are folks that I could call folks. I was stranded out on 460, way out in the middle of nowhere, right? I had a car, I had a flat tire, and I've got one of those cars that no longer has spare tires in them, right? And my tire was not, it was more than just a puncture, so the little goo wasn't working. So I was in the middle of nowhere. It was Sunday night. It was dark. Nobody. No, it wasn't raining. Thank goodness. Oh, thank goodness. I tell you what, it was awful. I was coming back from actually a tennis tournament, believe it or not. So, which I didn't do so well in, but it's another story there. But in any case, believe it or not, I made a phone call, and within a few moments, I had 3 people who were amongst the closest of my friends give me a call and ask if they were going to drive over an hour and a half just to come get me at night and figure out what to do. Now that is being blessed beyond belief in many ways. That is what life is about. More important than anything else. So when I see a lot of folks and they say, I want to live until I die in my home, which is what my dad tells me. I go, yes, Dad, because that's what he wants, and I will do my best to respect that. But we have many a heated conversation about how that may not be the healthiest way to live. But that was his value. He built a house from scratch specifically so he could die in place, which is a laudable goal, but one which may not really be as wonderful as he had thought. Right? So you can't get that always at home. And that's where an organization like this can be helpful. Yes, ma'am?
I listened to an interesting radio talk show with a neurologist who talked about as we get older, the benefit of developing skills to the point where we're proficient, like juggling, where you just keep juggling every day and to be really good at it, that it creates new pathways in our brain. Do you believe that's true? And if so, does that create brain health, sir?
That's a great question. The answer is yes. But if you don't like juggling, don't juggle. right? Create new pathways by doing other things, like play tennis, if you've not played tennis, right? I'm just saying, I'm throwing it out there. Play chess, equally as important new thought pathways, right? So it is true, learn new skills, do new things. Very good for health, right? But do it, right? I have a lot of folks that talk about it, but they don't do it. But you got to do it. If you want to be a juggler, there is nothing wrong with juggling. Juggle, right? If you want to play pickleball, play pickleball. If you want to play tennis, play tennis. If you want to do something else, go do it. Cycle. Go bike. Do something that's fun. Hike up Candler's Mountain, right?
No, thank you.
But do stuff. So that's key, right? So both mental and physical. The beauty about juggling and playing tennis, right, is that it requires both the brain and the body, right? So, but you get the idea. Do something. Learn something that's hard. Different. Not always. Maybe just trying harder amongst yourself. For example, crossword puzzles are really fantastic, right? Just not my thing, right? Playing Scrabble, that's great, right?
How about word search?
No! Awful! No! It's fun. Word searches are fun. But think about what the difference is, right? When you do something that has a small set of rules that are repetitive, is that taxing your brain? No, right? So word searches, I'm just looking for the letters and I'm just going through the process. Is that fun? Yeah, I've done word searches and they're kind of fun sometimes. I gotta tell you, right? I mean, there's nothing wrong with it. So it's not bad to do word searches, it doesn't hurt you. But you can't do that and say, that's my exercise for the day, right? You can't do that. It's got to be something much more complex and complicated. Solitaire, same thing. Black queen goes on a red king, right? It's not gonna, I don't care how fast you are. It's not gonna tax your brain, right? But if you start doing some other tasks and activities, that's where Scrabble is good. That's where crossword puzzles are good. That's where doing other things. But card games by themselves, very fun, probably not going to be incredibly taxing, right? So just sort of, it doesn't matter if you say, oh, it's complicated. I know all the statistics associated with 7-card stud, right? Or draw, or whatever it is. I don't play cards, right? The point is that it's only a set number of rules that you apply over and over and over. So it's fun. Do it. Just, A, don't lose money doing it, right? And don't expect that to replace the other tasks and things that you do.
So that's not working the brain.
It's not working the brain.
How about going back to your father or your situation, moving from a home to an active adult community to an assisted living to a memory care? What signs would you look for along those pathways?
That's a very good question.
Would you repeat the question?
The question is, what can I ask that you have no answer for? He asked the question, he says, well, how do you make the decision between living independently and living in an assisted living facility and living in a memory plus some supportive assisted living versus a memory care setting versus a nursing home setting, which may be different than a rehab type setting? That's a really big transition. Well, I'll tell you this. Did you guys know that I live in assisted living? You guys didn't? I bet none of you said, oh, there's Dr. Betz, he's coming from another assisted living place, right? But I live in assisted living.
You live in Westminster?
No.
Wife.
I live with my wife. Right? Let there be no question. She does a tremendous amount to help me take care of the house. I do a lot of work too. I'm not entirely a bump on a log, right? My kids help too, right? They clean the dishes sometimes. They take out the trash sometimes. But the point is that although I could live independently, right, I don't. And it's okay not to be independent. Matter of fact, I kind of like not living independently, right?
No, you wouldn't like it at all.
What, you mean living independently?
Yeah.
Oh, no, I like living dependently, right? Because I have, and I can honestly say that my wife is one of those very close friends of mine.
Good.
If you have a conflictual relationship, it may not be, right? But I've seen a lot of bickering couples that still are very tight and can be relied upon each other. So it's not always the nature of that. But those are important things. And so when I talk about assisted living, I really talk about what is right for you as an individual. So for example, my family, my dad, will live in assisted living in time. But that assisted living will occur in his home. He will miss the socialization that will be gained from living in a community like Runk Pratt, for example. But he will get assistance in time. And so assisted living has different meanings depending upon how you approach that. And we have a lot of that. So for example, there are a lot of facilities in town that say, gosh, we're assisted living, and then we have memory care, right? Well, guess what assisted living is? Memory care. But they don't like to advertise it that way. Well, guess why? Because you or I, we don't walk around this world, right? Sort of thinking, gosh, I can't wait to move into a memory care facility, right? Because you don't want to admit that you've got a limitation. So they don't label it that way. That's the problem with labels, right? It's that they're useful shorthand, but they have misunderstood connotations. So that's why I explain. I live in assisted living. Now, for you as an individual in your family, you might choose to provide that assistance in a number of settings. There has actually been a study that shows that if you live in a facility, living in a single room, which is what we would all expect our desire to be, right? Just like some people like to live in their own house. Some people like to go into a facility and have their own room. And we all create elaborate reasons for that. Well, you like your sense of privacy, and you still have some autonomy, and you still have some independence. Well, guess what? The data shows if you have dementing illness, you do better in a shared living environment than an independent living environment. Why? Because you have more forced socialization, interaction, problem solving. Bingo. Problem solving. Key. So actually, having problems to solve is better than not having any problems at all. That's a whole other fun topic. So, assisted living, retirement community, is exactly a good way of being able to maximize what you do. Does that mean you should say, you know, I've spent my whole life building this house and creating a family, and this is my homestead. I need to give it up now because of Dr. Betz and move into some other place? No. Just recognize that it may not be as bad of a transition as you might think initially in that process. And each family will transition at different points. What I don't profess is I don't profess, like families come to me and they say, well, should I make the move or not? Right? I tell them I'm not going to make that decision for you. What I will do is tell you what I think are the care needs of your loved one. And then we need to then decide, can you provide that care in the current setting, or do you need to get more assistance by moving to another type of setting? And how do you balance that? And every family is different. I've had folks that live at home that get better than nursing home care in any facility in town. And I've got folks that live at home and really get bad care, as well as folks that live in facilities and don't get the care they need for a variety of reasons. So it's not always a one-size-fits-all. There's not a line that you cross that says, aha, right? And so that's where balancing your needs, balancing the careability of the facility, right? Because I have a lot of folks, so for example, Runk Pratt, we have a lot of levels of care, right? There's everything from essentially memory care, which is nursing home care outside of a nursing home, right? All the way to independent living. And there's a whole spectrum. You can get independent living that has a little bit more support, let's say with medicines and meals, right? And then you can have independent living that has a little bit more support than that. And then they go into what's called official assisted living. Well, the reason they have all those labels, right, is because sometimes the more care you get, the more you got to pay. And so you've got to be able to define that in some way. But for you as an individual, it's a conversation with the organization. What can you provide in what setting? How can I support that? Those kinds of things. And so it's really a very much an individual process, as long as you're open to the variability of which direction that you can go in. So hopefully in a few moments, not a few moments from now, but in those few moments, right? I've explained to you how I might go about problem solving that very important question, but deliberately avoiding making a clear black and white statement, right? And there are times when it's extreme. I mean, there are times where I've had to send Adult Protective Services out to a family member's house because they clearly were failing and there needed to be an acute intervention, right? That just is what it is. But that's sort of an extreme version. Most of the time, it's somewhere in the whole spectrum in the middle of that.
How much of an impact on Alzheimer, dementia, is somebody that lives by themselves and kind of isolated? Does that have a big impact on it?
Probably has some of an impact. One of the greatest things that, that you can do in order to preserve brain function, are you ready for this, guys? This also flies in the face of what we've thought about as the best in the world, right? Never stop working. Problem solving, doing hard work. That is what preserves brain function. Because
And keeping close to your family members.
in many ways, you're exactly right. So living by yourself, isolated from others, not having to problem solve and interact and create sort of new bonds and relationships probably doesn't make it worse, but you're avoiding what could help reduce some of the disability from that. Does that make sense?
I kind of anticipated that.
Very good.
Do we have any other questions for Dr. Betz tonight?
How do you get them motivated to get them, everything's a no? How do you get a yes?
One of the that's a really good question. The and another one I don't have a good answer for, but I can tell you what I do know is that it is normal for folks that have dementing illness to develop what's called apathy, which is the lack of initiative. And if you lack the initiative, you don't spontaneously get involved in things. So I'm standing up here and I'm going to go, anybody who knows me, right, knows that I'm loud, I'm obnoxious, I'm active, I never shy away from too many things. How many of you would peg me as a loner? I am.
No kidding.
If I was left to my own devices, I would be very happy being by myself, alone, not interacting with folks. Every time I get a call, I have to make myself go. Not because I don't love the people I interact with, but because that's not my nature. Believe it or not. So when we develop apathy, we lack that initiative, and it's built into the disease, right? And when we lack that initiative, guess what? We need somebody else to make it happen. And so it does not mean, right? So for example, Christmas came around. I had more parties to go to than that I could fit in, right? And most folks have lots of events and the like. I had to make myself go. And actually I had to go to some events that I hadn't been to in a while because I wanted to make sure those people knew that I wasn't trying to ignore them or not interact with them and to do those kinds of things. I had to make myself do that. Now that's more about me than you guys want to know, right? But that's just sort of my style, right? And so, but with apathy patients, they don't go through that cognitive process. You can't convince them that it's a good enough thing they should go even if they don't want to. Because they're as content as they are looking at the wall as they are having a great time. The interesting thing is that once you get them out of the house, like if I go to a party, right? I have a great time. Standing up here, I am having a good time. I can talk all night long, right? I got zero issue with that, really, right? But I would much rather not, right? It's just the way that I am. That doesn't mean it's bad.
Because you guys don't play tennis.
It just
Yeah.
is what it is,
Yeah.
right? I do
Hard
need
for
to,
3 people to play tennis.
no, for three, you're exactly right, so I do need to head out, but they know I might be late, because they know I'm long-winded. So, so in that setting, the only thing that you can do, if you have a loved one that has that illness, is to be a cheerleader. And I love the word cheerleader. That doesn't mean you gotta walk around pom-poms, right? But it does mean this. What does a cheerleader do when the team is winning? Like for Alabama, who won the national championship, right? What do? They cheer, right? Yeah, right? What are they doing if they're the cheerleader for Georgia Tech? Where I went. Right? They don't go, you stink! Right? What do? Go team! Right? They don't say you dropped the ball again, fool, right? You made another interception, right? You didn't meet your expectations another year, right? They don't do that. What do, right? They're all up and going. And that's what we can be as cheerleaders. That's what the staff here, that's what Pam does all the time, right? You ever watch her? All she does is walk around, yeah, that's great, you just pooed on yourself, let's go! Right? Let's have a great time, you know? That's what she does, she's really good at that. I gotta tell you, because they come and they're seeing me and they poo all over themselves. You're all right, we're gonna get you all cleaned up. That's what she does, right? That's why she's good. Absolutely, that's why she's so wonderful. That's what's good. So that's all you can do. And sometimes when it becomes conflictual, you just got to say, is it really worth it? In this moment. 5 minutes later, 24 hours later, it may be different, right? But you've got, that's where the art of being a caregiver comes into play.
I want to add one thing to that. We all have family, we love our family, but there are people in our lives that do as much for us as our family does, and we forget to say thank you. And I'm saying thank you.
Great. I love that.
Well, we're gonna ask Dr. Betz to come back probably in the next 6 months or so. You all can get together, get with one of us. You have extra questions you want Dr. Betz to focus on next time he's here. He could speak for days on this subject because he's an expert on this. For med management, he's just a great ally of ours. He works with us. I mean, he's a good guy. And all of you know him. I haven't seen everyone, but I know a lot of you value what Dr. Betz has to say. And we want to thank everyone for coming. So we will see you next time. Thank you.